Hi, everybody. It is 7 minutes past the hour. I do apologize for a slight delay. My name is Mohamed Moti from the Sorbonne University and Saint-Antoine Hospital in Paris, in France, and it is my great pleasure to welcome you all to this journal club brought to you by the International Academy for Clinical Hematology. I think you are all now familiar with the journal club recipe, I would say. We've established this activity almost 4 years ago now, and it's proving to be extremely popular. So the paper that was selected today by the Scientific Steering Committee is this one published in Leukemia Lymphoma very recently. And the title is Efficacy of First-Line Tagraxofusp in BPDCN with prior or concomitant hematologic malignancy, subgroup analysis of a pivotal trial by Dr. Naveen Pemaraju and colleagues. And we're very fortunate having actually today with us Dr. Pemaraju himself. I think the other panelist, Dr. Onida, is a bit late. He is stuck in an emergency, but hopefully he'll be able to join us soon. So here I have copied and pasted from the paper what I would consider the summary. And this is a subgroup analysis from trial STML 401-0114, which tested the approved drug, actually, tagraxofusp in BPDCN. And the idea was to compare two subgroups, and these are the patient with BPDCN, but with a prior malignant disease. And to make a long story short, but we'll hear from Dr. Pemaraju, it looks like, according to this analysis, that the response rates were actually similar between these two groups. Just as a quick reminder to set the stage, you can see here the characteristics of these patient basic demographic and baseline disease characteristics of the patient included in the trial. And you can see median age was quite high, 68, 69, up to age 84. And these are patients who have quite high-risk advanced BPDCN with high-risk features at baseline, but also involvement of extramedullary sites. The median time since BPDCN diagnosis in months was roughly around 1 month. And I think here you can see the key message when it comes to the overall response rate. Obviously, the numbers are relatively small in the prior or concomitant hematologic malignancy patient, but still, I think it provides a clear indication about the efficacy of this drug. And this is actually the conclusion of the authors, showing that even in this subgroup of patients who are in theory at higher risk because they have another malignant condition, we can still actually use tagraxofusp with a predictable and manageable safety profile, which I think is an important piece of information. So I will just stop here. Welcome, Dr. Pemaraju. Thank you, Naveen, for joining us.
Well, thank you so much, Professor Moti, for having me again.
we're very proud having you, and congratulations for all of these wonderful publications. And I think you and your co-workers, you have dramatically, I would say, improved the outcome and the natural history of BPDCN, which is a very rare condition. And of course, we're fortunate that we have colleagues like yourself who are dedicated to these neglected, historically neglected entities. So before discussing the content of the paper, Naveen, just as a reminder to our audience, if you can kindly summarize the original trial, maybe the mechanism of action of the drug, and why this subgroup analysis was important, actually.
Well, thank you, Professor Moti, and to the entire IACH platform and team. I really loved your background. Really, to add to that, I would say 3 or 4 points. So, as you mentioned nicely, blastic plasmacytoid dendritic cell neoplasm, so BPDCN. It is this ultra rare leukemia subtype, if you will, now recognized both by the ICC and WHO classifications as sort of its own separate, if you will, myeloid malignancy. It's rare. I think it's probably 3 to 4 times more diagnosed than what we're seeing, maybe about 500 to 1,000 patients a year in America, maybe another 500 to 1,000 patients more in Europe, et cetera. As you mentioned, BPDCN is typically seen as a disease of older individuals. We see regularly patients 80s and older with this disease, although there is a growing contingent of young patients, pediatric and AYA. So with the BPDCN, historically abysmal, suboptimal outcomes, our European colleagues, who you and I know well, Professor Pagano and others, have published really 8 to 12 months as a median overall survival. And that's despite multi-agent chemotherapy, ones that groups all around the world, yours and others, have published on: multiple myeloma therapy, lymphoma therapy, ALL therapy, AML. So despite those multi-agent therapies, median overall survival around a year or less. The breakthrough came when we found that all these patients, 100%, are CD123 positive, IL-3 receptor alpha. And so that led to the breakthrough of the drug that you mentioned, the tagraxofusp, or we call it TAG for short. The original study we were able to publish in New England Journal some years ago now. So that was 2018, April of 2019. The drug was approved December of 2018 in the US. So the CD123 drug tagraxofusp as a single agent monotherapy, quite high response rates, 75% overall response rate in the 3-year median follow-up published in JCO, with a 57% CR/CRC rate. The question that led to this study that you're highlighting is a good one. Even though it's a rare disease, not much is known. We've made some breakthroughs, and it turns out that a lot of these patients, more than we thought, have another cancer with them. So the BPDCN is rare. It brings along another cancer, usually at the time of diagnosis or before. We give it this onerous name called PCHM, sort of prior concomitant hematologic malignancy. But this is similar to other diseases people are familiar with: SM, systemic mastocytosis, with AHN, for example. And so the last part of the background I would say is that because there's a significant percentage of these patients, we wanted to see what are their characteristics, what are their outcomes, and does the therapy for the BPDCN, assuming and thinking that that's a primary process, can that actually help these patients? And one final thing, Professor Modi, I want to say before I turn it back to you, we were surprised at how many of these patients will have another blood cancer. Usually it's a myeloid malignancy. MDS-CMML is the most common. That's interesting to me, followed by MPNs, but they also can have TALLs, Hodgkin's lymphoma, plasma cell dyscrasias. So the question to ask yourself, if it's such a rare malignancy, why it brings along another one that's usually more common, and do our standard treatments help these patients? That's the background for the study you're discussing here.
No, thank you very much. And I believe, well, you are the expert, but I guess that these are relatively old patients, and usually age comes with different malignant diseases. And the question is, and we have already a question from the audience, because of course the audience, did you screen for SHIP in those patients prior to inclusion and treatment?
Now that's exactly what you were about to ask and the audience member. So you guys nailed it. It is a median age of 68 to 69. That's on the study analysis. In the real world, maybe even older patients. Not on this study, not to get on the original trial, because back then we weren't even thinking about CHIP. But just to remind folks, clonal hematopoiesis indeterminate potential, very common as we get older, and has something like a 20% rate of going to an MDS AML. In a separate study that I did from MD Anderson with my pathology colleagues, we did look for CHIP. It was an astonishingly high rate. So you guys nailed it. I think older age, maybe UV light, smoking, other exposures, and a lot of these patients have CHIP. And furthermore, to your guys' point, guess what's the most common molecular mutation or variant in all of BPDCN, regardless if you have bone marrow involvement? So you can only have skin lesions, and it's TET2. So you guys got it. I do think that I love this discussion already, right? So why would you have a rare disease that has another MDS CMML? There you go. Maybe a lot of these patients have CHIP, TET2 mutations. They have some other environmental factors, skin lesions, bone marrow. There you go. So I think that's a huge component to it. In this particular subgroup analysis, because it was a prospective study, we didn't look at CHIP per se, and it wasn't a screening. But in general, yes, it is a common thing in BPDCN.
Excellent. Do you believe the TET2 mutation contributes to BPDCN?
I do. It's not in and of itself sufficient and essential by itself, but there was a study from our colleagues at Dana-Farber which showed that in combination with UV light exposure and a TET2 abnormal or deficient cell process, this sort of two-hit hypothesis can lead to these skin lesions of BPDCN. Furthermore, we found shared cases exactly like what we're talking about. This was published with our colleague Dr. Dan Wiseman, a patient with both BPDCN and CMML from the beginning, and TET2 was the shared clonal mutation with two divergent paths. So I think TET2 is very important in BPDCN, probably by itself cannot initiate or sustain it, but in combination with other aberrations and mutations, both intrinsic and external, it's extremely common. And I also want to emphasize, as we were talking about in the earlier segment, you can have present to me with skin lesions only. Oh my goodness, it's BPDCN. Bone marrow is negative. But if you still run the gene panel, as I do in all patients, you'll still find usually a TET2 mutation or variant, suggesting that this CHIP theory, TET2, is a really common part of BPDCN.
So if we are talking about the pathophysiology, I'd like to take here another question from Dr. Lisan, asking about the cell of origin in BPDCN.
Ooh, this is good. We're getting to the real stuff. So it was long debated, and I think still debate in our field. So one thing for our viewers, particularly those who've been following our field, see, the name has changed a bunch of times because the cell of origin was incorrect. Basically, it was debated. Initially, it was thought to be an NK cell or a lymphoma basis because it's a CD56 positive tumor which likes to go extramedullary, as we've seen in other CD56 positive diseases. So one of the older names was blastic NK cell lymphoma. So for some of our seasoned physicians, they know BPDCN as that. That was proven to be wrong. Then it was thought to be specifically a myeloid leukemia, like an AML, fine, but it has its own markers, TCL1 positive, TCF4, as you know. So now in the latest WHO ICC, BPDCN is its own malignancy. It does appear that the PDC, the plasmacytoid dendritic cell, so a subtype of dendritic cells essential for immunity, so secretion of toll-like 1 receptor factors, etc., it appears that that's the cell of origin. So we believe that it's a myeloid-derived cell, PDC, bone marrow, leukemia, basis. But that PDC likes to go, guess where? To the skin, lymph nodes, and unfortunately, it has a predilection for the CSF. And that's why those are the 4 compartments that you see: skin, bone marrow, blood, lymph nodes, and CSF. So the PDC is the cell of origin, we believe now, for BPDCN.
Well, plasmacytoid dendritic cell, I would also like to add, this was discovered by the late Dr. Ralph Steinman from New York. And actually, he got the Nobel Prize for his work and the discovery of PPDC. PDCs, and this is the only Nobel Prize which was given after his death, because
Oh, wow.
when
Good for you for that.
when the Nobel Prize was announced, actually the information about his death was like only a few hours before. So
What
that's
a trivia fact. That's a good one. And you're also reminding us these PDCs function in the normal immune system, right, Professor Modi? So
absolutely, they
like
are
receptor
they
pathway, they're
contribute
essential.
type 1 interferon,
Precisely.
antiviral immunity.
Precisely.
It's crucial, and actually we spoke a bit about them during the COVID pandemic. So let's move now to the clinical part, because we have a lot of questions, Naveen, here. And why specifically in this entity, actually looking into the response rate is already an important endpoint. Usually we would look to progression-free survival, leukemia-free survival, whatever. Why do you think, and in the original trial, it was also the primary endpoint, that
Right.
the overall response is crucial? Achieving a response in this entity is crucial.
I think this is an essential question. I think if we get away from science, one of the main things to talk about with BPDCN, since it's such a deadly disease, is that stem cell transplant in CR1, or at least in response 1, let's call it, is still an essential part of the curative journey. So the answer is, in real life, even if you don't quite get to a CR, so for example, a PR, or what we call, Professor Moti, a CRC, which means you've grossly reduced the disease and all the visual components, but maybe on the skin biopsy, there's some residual cells left. It's not quite MRD. We never defined that in BPDCN. So you get to a major response, which we define as a CR, CRC, or maybe even a PR. Those patients still appear to benefit. They've debulked their disease. Now you can either go for stem cell transplant if you're qualifying. You can go for repeated cycles, which in those repeated cycles, we have seen people convert from an ORR, let's say a CRC or a PR, into a CR, or it's an early sign that you have some response and you can either early switch therapy or go to combination therapy. So I would answer it in that way. There's a practical kind of a readout for ORR. The other thing I would also say is it's a new disease. And so what folks, this story, but my group and I had to invent these criteria from the beginning. And so what we decided, since it's such a heterogeneous disease, it's a messy disease, skin, lymph node, bone marrow, we picked those as the 3 compartments. At that time, we weren't really appreciating the CSF involvement. And so we borrowed. We took the skin assessment from Sézary syndrome, CTCL, the MSWAT, widely regarded. We took the AML bone marrow criteria from Chezin et al. And the lymph node from lymphoma criteria, Chezin et al. As well. Put that together as a hybrid but reliable prospective tool to measure response rate. So in that, we hypothesized that you would have patients who would benefit from the drug but not quite get to a CR. And that's what you're seeing here. Almost everybody responds to, for example, CD123 targeted therapy upfront. And even if they don't get to a CR, they can get to one subsequently in the subsequent doses.
Excellent. Thank you so much. We have an interesting question here about, you have focused on those patients with prior or concomitant hematologic malignancy.
Right.
Do you have an idea or information about those patients with a solid tumor? Because they may have had a prostate cancer or a colon, whatever, breast cancer many years ago. Were they excluded from the trial, or any data on this?
Oh, great question. Yeah, we only focused on the heme one because it was so much more common than we thought. So the only data I'll say to folks is that there are patients with solid tumor who then go on to have BPDCN, but there doesn't appear to be as temporal of a relationship as there is here. And many of those are in a remission beforehand. So, stay tuned. In the next year or two, you'll see publications from me and our group on that. But so far, I haven't made any observations of solid tumor to BPDCN. And certainly we have seen not many patients with a solid tumor concomitantly with BPDCN. It does happen, but I haven't seen any associations yet. We're still looking into that one.
Okay, wonderful. So let's move to the treatment part now.
Okay.
And just if you can kindly explain the mechanism of action of the tagraxofusp, targeting CD123, which is actually a common marker in other type of leukemias.
Right. Well, you got it there. So the three-line quick answer is that CD123, also known as IL-3 receptor alpha, sits on the surface of these malignant cancer cells, so not internal. So it's both attractive to pharmacological and immune therapy, and it turns out it's not too highly expressed on the normal bone marrow stem cells. It's there's a gradient there. So that's part one. Part two, BPDCN either expresses or overexpresses this target 100%. And then number three, as you said, it's not specific to BPDCN. So AML 75 to 90%, even ALL, both B and T will express it, Hodgkin lymphoma, hairy cell, mastocytosis, etc. So it's a surface target, highly expressed on BPDCN. Number two, the tag agent is unique, okay? So it's a diphtheria toxin that's modified, truncated, if you will, fused to a human recombinant IL-3. So it creates kind of a homing molecule, if you will. So you inject it into patients. It's an IV drug given quickly over 15 minutes. And then those cells home in to guess where? The IL-3 receptor alpha, which we just said is CD123. Boom. So they bind selectively. That leads to an internalization of the conjugated protein and then cell destruction. So the diphtheria toxin that's modified goes in, boom, causes irreversible protein synthesis and cell death of those highly expressing CD123 cells. Now, in so doing, you have two major results. One, as I mentioned, very high response rates because it's a very specific therapy for those cells. But two, there's a couple of other cells, unfortunately, that express CD123. So healthy endothelial cells, which line the heart and lungs, unfortunately will express that. And so that's why you'll see anywhere from 15 to 20% of patients may have what's called capillary leak syndrome. That's the unfortunate side effect on target, off tumor, but on target side effect, if you will. And so because you're able to kill CD123 cells, we hypothesize that you're hitting some of those cells in some patients, not all, not most. And that can lead to fluid buildup that has to be managed clinically. So Professor Moti, I think it's an ingenious kind of first generation CD123 antibody drug conjugate with a bacterial modified toxin, high response rates, but you have to watch out for this key side effect, which can be managed appropriately.
So this is exactly the question we are having about the use of the drug and the tolerance, the management. So you would use it for induction to induce a response. And according to the algorithm you mentioned, the idea is whenever possible to bridge these patients into an allo transplant.
Sure.
So the question we have, for instance, whether you can use the drug for maintenance after transplant. And for those patients who are not eligible to transplant, whether you're using any consolidation and long-term therapy. Are there any data there?
Yeah, so for the first part of what you said, correct. I would say still in 2025 and beyond, allo transplant, particularly in CR1, should be part of every BPDCN patient's journey, at least consideration of, counseling for, and then if you're young or fit enough to go for it. The earlier, the better, probably. On the original TAG trial, you'll see that we were able to transplant half of our patients despite the older age, most of whom were allo. There were a few select auto cases, but that is in an older group of patients. And usually the median doses of TAG is anywhere from 2 to 4 doses. So generally earlier on. Number two, not everyone can go to a transplant. So as you're asking, there are consolidative approaches. You can get TAG. We've had patients who've gotten it for years on end. So there's no problem with giving TAG over time as its own consolidation and maintenance. Number two, there's combinatorial studies now where we give TAG aza-ven or TAG hyper-CVAD-ven. And then number three, there is a movement in the field that perhaps you get to a maximal response and either due to toxicity or other reason to switch then to say an HMA-ven approach, et cetera, particularly in an older patient who doesn't go to transplant. But part two is very important. We have young fit patients who are going to transplant and who are still deemed high risk for relapse, given a number of factors that you can imagine prior. And you're right, we're still investigating that. We have done TAG post-transplant. We'll have a publication coming out soon on that. So that's feasible and you can do that. And people around the country and particularly in Europe, where the drug is available in some countries, have given it off protocol. You have to watch out for LFTs, GVHD, et cetera, maybe even VOD as well. And then number two is the concept of HMA-VEN perhaps, or other more AML myeloid-based maintenance for 1 to 2 years after. Have to emphasize that it's not standard. Even I myself do it on a case-by-case basis, usually chatting among the other team members or BPDCN investigators. 2, we have yet to finalize and formalize an MRD, which AML and ALL both have. So my plea to the international group, this should be our next urgent unmet medical need, which is defining MRD in the blood, in the bone marrow, in the lymph node, in the skin for BPDCN to then determine what you're saying. And then finally, number 3 is how to separate post-transplant toxicity from CD123 toxicity. Again, VOD, GVHD, LFTs, sometimes it's difficult. So timing post-transplant and also delivery. Finally, Professor Mothi, there is the concept of CNS relapse. In the earlier days when we gave cytotoxic chemo, perhaps the rate was less. Then we moved quickly into the targeted therapy era, which many patients was either monotherapy with anti-BCL2 or CD123. Then we started seeing CNS relapses again, likely because these agents as monotherapy don't cross the blood-brain barrier. So now that we've moved into adding lumbar punctures to all patients pre-transplant, I usually give 8 total, IT, Ara-C alternating with methotrexate. I do recommend still, if we can, 4 lumbar punctures post-transplant. As you and I know, that's a sanctuary site for these diseases. And then as we think about combinations, to not forget about the role of cytotoxic chemotherapy, myeloma-based, lymphoma-based, ALL, AML, which can add to the CD123 and BCL2, cross the blood-brain barrier, and perhaps prevent CNS recurrence from ever happening in the first place.
So that's exactly, you're making my life very easy, Naveen, because that is one of the questions we had, that with tagraxofusp alone as a single agent, we have almost 60% CR rate, which is quite high. Can we optimize this and push more patients into CR and maybe deep MRD negativity by combining it with more conventional chemo regimens?
Absolutely, I think so. We have several trials ongoing, so hopefully we'll update the world community in the coming congresses, perhaps as early as this year or next. But there's 3 approaches that are really important to highlight to the viewers. One is combining the TAG with hypomethylator and venetoclax. So let's call that TAG aza-ven, or there's other CD123 drugs that are in investigation, pivekimab sunirine, and other CD123 drugs. But what we're doing in these experiences is in either the older unfit patient or even the younger patient, upfront combinatorial therapy, doublet and now triplet to hit the major things. So BPDCN is highly dependent on BCL2. There's earlier reports, Laribi et al., showing hypomethylator as a single agent, but all these single agents are usually transient, right? So if you combine, can you not only prevent relapse, but can you then maybe even get patients to a deeper response, as you said, transplant, and then have a more sustained? The other approach is combining cytotoxic chemo. My group with Dr. Kantarja and myself are leading the effort where we're combining TAG with the hyper-CVAD, so the old Kantarja ALL regimen, which penetrates the blood-brain barrier, has active agents, including even dexamethasone, which is highly active in BPDCN, and giving the VEN. And then again, you have the added advantage of trying to decrease that. Your group and others have published on other ALL regimens, so older AML regimens. We have myeloma regimens that are active both historically and in the current era. CHOP lymphoma has historically shown some activity. So I would say in 2025, Professor Mothi, yes, there's still a role for not only combination to improve the response rates, but to decrease CNS relapse, so to prevent it altogether, improve the duration of response, and then improve the outcomes for pre and post transplant. It's actually an important aspect because I don't think we're curing patients alone with monotherapy approaches. We've got to do combination.
Super. One other question, because we're speaking about combinations, and in case these patients are going to proceed to allotransplant, is there any preference for a conditioning regimen, TBI-based, non-TBI-based, especially given the skin localization, the CNS sanctuary?
Oh, great question. Yeah, so there's a couple of nice papers that have come out on this. So we haven't come up with a formal one world approach for stem cell transplant, because there's been several successful ones. I don't want to highlight those. At MD Anderson with Dr. Kazelbash and Bashir and our team, we've had a great success with a flu-bu, more traditional, sort of a more older AML myeloid approach. We do favor, the full intensity approach rather than the reduced intensity, of course, if patient can tolerate it, thinking that this may help to eradicate some of the last BPDCN stem cells. Our colleagues, led by our friend and colleague, Dr. Karfan Dabaja and group, have published really nice results showing the addition of TBI exactly as the audience member is asking. And I think you guys are right. I think both because of the skin predominance, but also because of eradication of some deeper cells, that has really shown to improve outcomes. So I think that's a great approach as well. I have to also say, strangely, interestingly, provocatively, we had a few patients who were either skin only or older unfit for allo. And you, as with your transplant expertise, will appreciate, we did do auto transplants in those. That's 3 patients on the original study that we're discussing here. Our Japanese colleagues, Dr. Aoki and all, have shown in blood. Again, that's interesting. You usually give beam chemo, some high dose chemo, and then rescue with the patient's own cells. That's had some limited success as well. So I think what you're seeing is BPDCN is a high dose chemo sensitive disease, which is why I think we shouldn't forget about it. Penetrates into the skin and central nervous system. So traditional sanctuary sites that the usual chemo may miss. And then it's a radiosensitive and steroid sensitive disease. Overall, Dr. Kantarjian calls this appropriately the total therapy approach, right? So you and I know this from your early days in myeloma, now my modern days in BPDCN. I think what you're hitting on and why I'm so excited in this discussion is we have had success in borrowing a little bit of each of these modalities, because when it comes back, it's disastrous. So relapse BPDCN, the overall survival is 6 to 8 months as a median, 6 to 8 months, so far less than a year. And that's despite going on clinical trials, subsequent CD123 therapy, cytotoxic. So total therapy up front, my friend, you and I have talked about it for over 2 decades. I'm dialing that up for BPDCN. Let's try to cure these patients before it comes back.
Wonderful. One last question, Naveen. So TAG has been a true breakthrough in this disease, targeted therapy, high efficacy, and it's now more and more widely used. What are the next steps?
Excellent. Yeah, and I want to take a moment to also praise not only this drug, but the sponsors and the stakeholders. It's been a great experience to bring a rare disease like this to the forefront, and also want to thank folks such as yourself who have disseminated before, during, and after COVID time, as our research has really exploded. It couldn't have happened without you and your team as well. 3 things for the viewers to keep in touch, Professor Mothi, as we expand. I would say first theme is 2nd generation CD123 agents. So the TAG has revolutionized the field, New England Journal, FDA approval, EMA approval, as we mentioned here, and that's been amazing. But there are other agents, pivekimab sunirine, formerly known as IMGN 632, in late stage development. Let's follow that progress to see if there might be one day more options for BPDCN. There's bispecifics, CAR Ts, you name it, against CD123. Again, the theme is an outward surface marker that's susceptible to immunochemotherapy. Number 2 development to keep your eyes on is that of combinations. You nicely highlighted here, but there are other combinations we haven't mentioned that are either being developed or in process. So stay tuned for that. So not only doublets and triplets, but maybe quadruplets and quintuplets. And then I think the third area that might be of some interest to folks is identification of new targets. So rather than historically borrowing from AML, ALL, that single cell sequencing, deeper sequencing, looking at pediatric AYA versus older patients, European, Asian, African cohorts, Indian cohorts, as we're starting to collaborate, these international consortia, we're part of one with Gevorg Tamamian and team in Armenia, we might find in the next few years some new targets. So for the pharma stakeholders, funding agencies, philanthropic entities, stay tuned, because we may be approaching all of you for new targets that are specific to BPDCN as we now understand more about the biology.
Wonderful. Thank you so much, Naveen, for this beautiful journal club. Thank you all for joining us today. and discussing and sharing your thoughts, your questions on BPDCN and the role of tagraxofusp. I think we've seen how this targeted therapy marks a significant advance in treating an ultra-rare and aggressive disease, offering new hope where options have long been limited. But as also mentioned by Dr. Pemaraju, in this kind of ultra-rare conditions, continued collaboration and clinical research remain essential to optimize outcomes and expand our understanding. All of us at the ICH, we appreciate your engagement and look forward to future discussions to continue help moving this field forward. So stay safe, and thank you for being part of the ICH community. See you soon.
Bye, everybody. Thank you.